The causes of OSA have been clearly determined. With the subject in an awake state, the tongue is forward and the airway open. When the subject is asleep and prone, the tongue moves back, blocking the airway. Partial obstruction produces snoring. Complete obstruction results in an apneic event. In this MRI, the airway is shown as narrow but still open. During sleep, this patient will snore violently. The site of the upper airway closure is in the pharynx, between the nasopharynx and the glottis. Two of the more common areas for closure are behind the palate and at the base of the tongue. At sleep onset, there is a decrease in upper airway muscle tone. In predisposed individuals, there is a large rise in airway resistance as increasing respiratory effort is made. This leads to snoring, which is vibration of the airway soft tissue. Eventually, the airway closes and the apnea is sensed by the brain and arousal is triggered so that respiration can resume. The pattern repeats itself over and over during the night, in some patients hundreds of times. The continuous cycle of halted breathing followed by arousal can lead to a number of significant physical and psychological problems. The result of an apnea is a decrease in oxygen level, and most apneas and hypopneas end with an arousal. Frequent arousals lead to sleep disruption and may produce excessive daytime sleepiness and impaired daytime performance. Excessive daytime sleepiness is experienced by many patients and may lead to cognitive problems, social and marital problems, and a significant increase in motor vehicle and industrial accidents. Between 40 and 60% of patients with OSA have hypertension, and evidence suggests that untreated OSA is associated with hypertension even when other risk factors are controlled. Adequate treatment of OSA has shown to reduce blood pressure. Cerebrovascular disease and cardiovascular morbidity and mortality are more common in patients with OSA, and vascular morbidity is a leading cause of death in patients with untreated moderate to severe OSA. One study found a mortality rate of 37% in untreated patients with an apnea index greater than 20 per hour. This versus 4% in untreated patients with an apnea index less than 20. The mortality rate was 47% in untreated patients over the age of 50 with an apnea index greater than 20. As well, OSA may be an independent risk factor for neurological, psychological, and endocrine dysfunction. The treatment of OSA falls into three categories: medical, surgical, and dental. In the medical area, certain physical measures may be effective, such as weight loss, stopping smoking, avoiding alcohol, not eating late in the day, and eliminating nocturnal sedation. Pharmacological intervention offers little relief for OSA unless the site of the blockage is in the nasal area. In such cases, certain nasal corticosteroid sprays may be helpful. Nasal continuous positive air pressure, or NCPAP, was introduced in 1981. In this system, the patient wears a mask and a pump blows air into the mask at a predetermined pressure, generally between 5 and 15 centimeters of water pressure. The continuous flow of air acts as a pneumatic splint, which prevents the airway from closing in. While this gold standard of treatment may be 100% effective, many patients report problems with nasal infections, skin eruptions, and sleep partner disturbances. These problems have resulted in a decreased level of compliance by patients. Tracheostomy, corrective upper airway surgery, and uvulopalatopharyngoplasty, or UPPP, are all surgical options for the treatment of snoring and OSA. The success of these procedures often depends on patient selection. Other surgical procedures for these conditions include tongue reduction, tongue advancement, mandibular advancement, and maxillomandibular hyoidal advancement. All of these involve intensive and invasive surgery and are not readily available. The problems of long-term compliance with CPAP therapy and the limited success rate of surgery have led to interest in non-invasive forms of treatment that are safe and effective. For treatment to be successful, it must be comfortable and convenient, so that compliance is a natural step for the patient. The development of oral appliance therapy has been a major step forward in the treatment of snoring and sleep apnea. Dental appliances function in three basic ways: Some reposition the elements of the oropharynx which are involved in snoring and apnea, the tongue, the soft palate, and the uvula. Others stabilize these same elements. Still others stimulate and thus create tone in the genioglossus muscles. Let's look at some of these appliances in greater detail. Tongue retaining devices, or TRDs, use negative pressure to hold the tongue in a forward position inside a plastic bulb. There may be a tendency for the tongue to become sore and inflamed in some patients with continued use of these devices. There are a number of different palatal lifters. These lift the soft palate and uvula. However, these devices have not gained wide acceptance, perhaps due to their position in the area of the mouth which involves the gag reflex. Mandibular repositioning appliances come in a variety of designs and complexities and work by holding the mandible and consequently the tongue in a forward position during sleep. A relatively small anterior movement of the mandible, and thus the tongue, increases airway volume and can eliminate snoring and also apnea. Many of the available mandibular repositioning appliances hold the mandible in a pre-selected and fixed position. Fixed position appliances may cause problems for patients with temporomandibular joint disorder. Unfortunately, the same age group who may suffer most from snoring and sleep apnea also suffer from bruxism and TMJ problems. The silencer is a two-component articulated mandibular advancement appliance. The articulating element is a patented precision attachment. This dental device is designed to permit the advancement of the mandible through a controlled range of forward movement. The silencer overcomes joint and muscle problems associated with fixed position appliances by allowing vertical and lateral movements of the mandible. The silencer allows up to 6 millimeters of lateral movement and 1 millimeter of vertical movement while still holding the mandible in a forward position. The key feature of the silencer, which allows for this flexibility, is a patented precision attachment known as the Halstrom hinge. The hinge is constructed from implant-grade 6-4 titanium alloy and carries a lifetime warranty for the patient. The Halstrom hinge is the feature of the appliance which allows and controls the necessary movement of the mandible, while at the same time achieving sufficient advancement of the tongue to relieve both snoring and apnea. The body of the appliance is fabricated from a combination of elastomeric material and hard acrylic. The elastomeric material delivers a measure of comfort for the teeth and supporting structures. The hard acrylic is used to retain the hinge and also acts to increase retention with cross-arch bracing and to hold any necessary clasps. In addition, the cusp tips rest in hard acrylic, which acts to maintain tooth position. There are also hard acrylic bite pads, which are used to provide support to the dentition as well as the temporomandibular joint. In private practice, the silencer has proven effective in a high percentage of the cases treated. The silencer is effective because it moves the tongue forward and out of the airway. In this first MRI view, consider the patient to be in a supine position with the tongue crowding the airway. With the silencer set at 60% of the pertussive capability, the airway is more open. However, the soft palate and the uvula are still resting against the posterior wall of the pharynx. The silencer is now set a further 2 millimeters forward. The soft palate and uvula are now lying against the tongue, leaving the airway open and unobstructed. The silencer is now 2 millimeters further forward. The airway is even further open. This is an axial view of a small airway without the silencer. With the appliance set forward, the airway is much enlarged. The silencer allows gradual advancement of the mandible to open the airway.